I'm Professor Kaushik Ray, and I'm Professor of Cardiovascular Disease Prevention at St George's, University of London in the UK. Last week we published online in the Archives of Internal Medicine a meta-analysis, a systematic review of all the primary prevention trials of aspirin, looking at the risk-benefit of aspirin in healthy people. So secondary prevention is where you are looking at populations that have survived either an acute myocardial infarction or a stroke. So they've already had an atherothrombotic event. And primary prevention, this is basically a population that may have risk factors for heart disease or stroke, for example, high blood pressure, smoking, family history, or combinations of multiple factors, but who have yet not had a heart attack and a stroke, so are otherwise generally healthy people. And what the early trials have suggested was that there might be benefit for aspirin in primary prevention. There was obviously a bleeding risk associated with that, and more recently, the trials that have been published have shown no net benefit of aspirin. So there was a lot of confusion about whether aspirin in primary prevention in contemporary practice is actually beneficial or not. So there was a meta-analysis published in 2009 with 6 studies. There have been 3 more recent studies involving populations with diabetes principally, or with peripheral vascular disease, but without a history of MI or stroke. So in adding these additional studies gives you an increase in power, but also we felt that the previous meta-analysis had not dealt with risk-benefit, looking at absolute risk versus absolute benefit in a way that we would have liked, and it talked a lot about relative risk. So we wanted to basically further quantify that. Furthermore, there had been studies that had been done, not in primary prevention, but in mixed populations, i.e. half of these people had a prior history of cardiovascular disease and the other half were actually healthy, looking at the effect of aspirin on cancers. But that was a study in 25,000 people. Our study is purely primary prevention in 102,000 people. So what we showed is in 102,000 people with about 700,000 person years worth of follow-up, that if you look at the effect of aspirin on cardiovascular death, there is no significant benefit. The point estimate is about 0.99 with equally spread confidence intervals. So the question about whether aspirin impacts on reducing fatal vascular events if you're healthy, the answer unequivocally is no. What aspirin does do is it reduces the risk of non-fatal myocardial infarction by about 20% in relative terms. And what it does is, in absolute terms, for every 162 people you treat for about 6 years, you prevent 1 non-fatal MI. Now the flip side of this is bleeding risk, and this depends upon what you consider to be a significant bleed. Our definition of what we call non-trivial bleeding, which is very similar to the American Task Force guidelines that look at, again, what they consider moderate bleeding, would be retinal bleeding, non-fatal intracerebral bleeds, fatal bleeds, GI bleeds that require a transfusion in hospital. So these are all essentially bleeds or retinal bleeds as well. So these are all bleeds that would be considered to have considerable mortality or morbidity associated with those. And what we found is there was a 31% increased risk of that. And in absolute terms, that meant for every 73 people that you treat for 6 years, there's 1 extra bleed. So at a population benefit at level, for every 1 heart attack that's non-fatal prevented, there are actually 2.5 extra non-trivial bleeds. When you look at, for example, the effect on cancer, we did not find a significant reduction in deaths from cancer. We had over 1,500 cancers compared to the earlier study that was done in mixed populations, which had about 600 cancers. We had many, many more. We didn't have further information on types of cancers, but there are 2 caveats here. One is that even though we didn't find a significant benefit over 6 years, that doesn't preclude a benefit over a longer period of time, perhaps, or in specific types of cancer. But I'd also draw a little bit of caution here, because for any of the cancer deaths that were averted, there was about 3.5 to 4 extra bleeds. And one of the things about aspirin and one of the things about cancer is that cancer often presents insidiously and slowly and often with bleeding. Now, if your treatment makes you bleed more readily, then you're more likely to be investigated. If you're investigated, you might detect disease at an earlier stage. If you detect at an earlier stage, your survival chances are likely to be better. So part of the so-called benefit on cancer deaths may be related to what's called detection bias. So this is a very different scenario from looking at incident cancer. We have equal surveillance in both arms. You have equal imaging or diagnostic tests being done. That's a different scenario. That's not what we're talking about. But overall, what you can say is if you are a member of the general public over 6 years, would taking aspirin be beneficial? The answer is that there are benefits on non-fatal MI, but these appear to be outweighed by the risk of bleeding. The two important things that we did also show was that if for whatever reason your absolute risk is very, very high, then there might be some net benefit there. But the bleeding risk also goes down by reducing the aspirin dose to alternate days. So if you are going to take it in primary prevention, probably the way to take it is an alternate day regimen. We also found that prior to 2000, that the studies had shown very little benefit of aspirin, whereas more recently, prior to 2000, the studies had shown benefit, but post 2000, there was very little benefit from aspirin with respect to cardiovascular event reduction. And part of the reasoning behind this may well be that background therapy has changed. So better use of statins, lifestyle management, blood pressure lowering, and that might be part of the rationale behind this. And indeed, in the 2009 meta-analysis published in The Lancet, there was a modelling experiment done where they looked at what would happen if you reduce background risk by 50%. And the net benefit of aspirin diminished significantly. So in the modern era, probably it doesn't make sense to routinely take aspirin in everybody, but at the level of the individual, then physicians should consider individual risk benefits.